السلام عليكم ورحمة الله.
Waalaikumsalam, Doktor.
How are you? Good morning for everyone. How many students are you? Can you hear me?
Yes, Doctor.
Yes, can, Doctor.
How many students?
Total 8.
So where is number 8? 1, 2, 3, 4, 5, 6.
Include you should be 9.
Yes. So is the remaining one? Anyone absent? بس معايا المدرس اللي قلت لك عادي هتعرف لسه صلي ولا اروح في اوضه ثانيه؟ Okay. So please someone contact your colleague, the remaining one, okay? And let us start by الكتاب. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. Tell me how presentation do you have today?
Have 4 presentation.
4 presentation. Okay. You need to send me with your colleague the name and the metric number and the procedure, okay, in one message. So I give you marking at the end, inshallah. Let us start by the first one. Is it Khair? Okay. Okay, go ahead. During your presentation, we'll try to mute our microphone, so no need to disturb here. Unless someone need to ask, he can open, okay?
Okay, Assalamualaikum. Today, our group C will be presenting procedure regarding me. I will present about arterial blood gases and venous blood gases. Okay, next. Okay, arterial blood gases, or we also call ABG, is a test to measure the acidity and levels of oxygen and carbon dioxide in blood from an artery. And it is used to assess lung function as a gases exchange. Is the gases exchange function is properly functioning or not? And then ABG is the blood is drawn from artery, radial, brachial, or femoral artery, and the most common is from radial artery, and that's in the pictures is the side of radial artery. And for ABG, caution must be taken with patient on anticoagulants. So if the patient is on anticoagulant, we have to we should not take ABG. Helps so ABG also helps to differentiate if the patient is having oxygen deficiency from primary ventilatory deficiencies or from primary metabolic acid-base abnormalities. And then ABG is measuring partial pressure of oxygen, partial pressure of carbon dioxide, pH, bicarbonate ion, and also oxygen content and oxygen saturation. Next. So this is the normal ABG values. In the most important values that we need to look for in ABG is pH, PCO2, bicarb, and PO2, partial pressure of oxygen. So in arterial, the normal value for pH is 7.35 to 7.445. For PCO2, it is from 35 to 45 millimeter mercury. For bicarb, 22 to 28. For oxygen, partial pressure is 80 to 100 millimeter mercury. And for venous is the other one. And then that's for that is the interpretation for ABG values. If the pH is less than 7.35, the patient is in acidosis, and if it is more, is alkalosis, and then we have to look for CO2 and CO2 value and bicarb value to determine if the patient is having respiratory or metabolic acidosis or alkalosis. Next. So for indication for ABG, it is to assess ventilatory status, oxygenation and acid-base status, and it is to assess the response to any therapeutic intervention such as mechanical ventilation in patient with respiratory failure, and it is also to check if the patient is having any severe breathing problems and lung diseases such as asthma, cystic fibrosis, or chronic obstructive pulmonary disease. Next. So for contraindication of ABG, we have to take precaution. We should not perform ABG in patient with peripheral vascular disease if the patient is having cellulitis surrounding the arterial site, and then if the patient is having arteriovenous fistula, and if the patient is in bleeding condition. So this is the absolute contraindication, and then the relative contraindication if the patient is having impaired coagulation profile, if the patient is in anticoagulation therapy or in other condition. Next. So for complication of ABG, it is a painful procedure. So it is so the complication is pain since it is a painful procedure. And then patient may have hematoma or bleeding, infection, arteriospasm, air or clotted blood emboli, and since the methodology, since the how to take, since we need to apply local anesthetic, so patient may have anaphylaxis from local anesthetic, and since the artery, the radial artery is close to the median nerve, so we can damage the nerve nearby nerve, and then patient may have digital and distal limb ischemia, and especially in neonates. Okay, next. So these are the equipments or preparation that we need, to have before perform the ABG procedure. So first, we have to assess the patency of radial and ulnar arteries. So we have to do the modified Allen test, and then we have to prepare all the equipments beforehand. So those are the equipment needed for arterial blood gases. And then we have to note that is the patient currently receiving any oxygen therapy, since the oxygen reading will be affected if the patient is on oxygen therapy. Okay, next. So these are the modified Allen tests. How to do the test? We have to operate the radial and ulnar arteries both simultaneously while the fist is clenched, and then we have to ask the patient to open the palm and then see if the palm is pale, and then if the palm is pale, so we should occlude. We should release the pressure from the ulnar artery. If the color return within 15 seconds, the patient, so there are adequate arterial circulation of the hand. Next. Okay, so how to perform ABG? First, we have to put on glove, and then we have to prepare the site. So drape and cleanse the radial area with alcohol and position the wrist. So in ABG procedure, we have to keep the wrist in hyperextended position, and then we have to palpate the radial artery with the non-dominant hands, and then plan the puncture site. So if the radial path is identified, we can puncture the skin. And then if other than radial path, we can also use in posterior tibial artery or dorsalis pedis artery for ABG for arterial blood gases. And then once we identify the radial path, we have to open the arterial blood gases kit. And in pediatrics, since this procedure is painful, so we need to apply a topical analgesic an hour before the procedure, and then line the needle perpendicular with the artery. Later, I will show you the video how to do this, how to do the procedure. Next. And then after the once we set the needle perpendicular, then we can puncture the skin. So we have to when we puncture the skin, continue to advance the needle slowly towards the pulsation that we palpate previously until you feel a sudden reduction in resistance and there is a flashback into the shrink. So the ABG shrink should then begin to self-fill in a pulsatile manner. So we have to let the blood fill into the shrink spontaneously, and then withdraw. Then once we get enough blood, withdraw the needle and hold pressure firmly on the site. Um, since we use an arterial blood, so it have high pressure, so we need to press firmly on the site. So and then protect and remove any air bubble from the needle. Gently mix the specimen by shake a little bit the needle, and then place the specimen in cold box and transfer immediately. Continue to apply firm pressure to the puncture site for 3 to 5 minutes to reduce the risk of hematoma formation. Okay, next. So these are the video on how to perform OBG. These are the equipment. No sound.
James, I'm just going to do a quick test to assess the blood supply to your hand. Could you just make a very tight fist for me? And hold it there. I'm now going to press on each side of the wrist. Keep your fist as it is. And relax. James, that's the end of the procedure.
Okay, next. Next is VBG. Next. So the indication is basically similar with ABG. However, for in ABG, we want to measure the systemic carbon dioxide and pH, and usually it is to assess a ventilation function. And for VBG, we want to see the systemic pH and carbon dioxide. However, without anticipating any ventilatory problems. And for NVBG, usually it is more preferable since it is less painful and it is easier to perform. Okay, next. So for contraindication, usually there is no there is no absolute contraindication for VBG. However, if possible, we need to avoid any infected site. We have to avoid taking blood from a site of burn, any injured site, and we have to avoid taking blood from the arm with IV fluid transfusion or medication, and then we have to avoid hematoma site and edematous limbs arm. Okay, next. So for complication, it is similar with ABG. However, in is similar with ABG. However, in VBG, it is less painful, and then we are not really worried about bleeding or thrombosis. So this is the complications. Next. So for the steps in VBG, it is similar with ABG. We have to use the heparinized syringe, and then it is similar. However, the introduction of the needle is a different angle. So in ABG before, we have to puncture 45 at 45 degree angle. For VBG, we can puncture at 15 to 30 degrees angle. And for next for VBG. Next. Oh, no. For VBG also we have to use a tourniquet, and for ABG we doesn't have to use a tourniquet. Okay, next. So these are the difference between ABG and VBG. So ABG usually it is painful, and we have to anticipate any anterior artery injury, thrombosis with distal ischemia, hemorrhage or hematoma, and ABG can cause aneurysm formation, median nerve damage, infection, middle stick injury, and we have to anticipate any reflex sympathetic dystrophy, since we use the arterial, since we flushing the arterial blood. And then for VBG, it is not as difficult as ABG, since the samples can be drawn simultaneously at time of venipuncture, and then it should be done. It should be done with a tourniquet, and then it is more difficult to obtain in pulseless patient. However, there is a controversy regarding level of agreement with arterial values. Next. Okay, so these are the mnemonic to interpret ABG, to interpret blood gases result. So if in respiratory problem, the value should be in opposite value. So if the pH is high, PCO2 is low, so it is alkalosis, and if the pH is low, it is acidosis, and PCO2 is high, so it is respiratory. So for metabolic, it is the value should be equal. If the pH is high, carbon dioxide, bicarb is high, so it is alkalosis, and the pH is low, and bicarb also low, so it is acidosis, metabolic acidosis. Okay, next. That's all for ABG and VBG. So basically, the ABG is for it usually, preferably we take blood from VBG. However, to assess to accurately assess the ventilation problem or ventilation function, so we need to do ABG. That's all.
Okay, and thank you, Sister Laila.
Can we stop for a while, please? All of you are able to got the knowledge of arterial and venous blood sampling or cannulation? Okay, can you start from your presentation? Come back, please, for the arterial complications. Yes. Complications, okay. Yeah, it is very important to know the complication, not to be afraid to do it, but try to avoid, and even if some of them cannot be avoidable, to be able to intervene early, okay? Because someone said if like that, it can cause arterial spasm or thrombosis or whatever. Why you are doing? Yes, you need to do, because arterial cannulation sometimes are very important, especially if you are working in ICU situation, like in the ICU, PICU. It is very important. Sometimes it is the same. You are getting the sample of the artery. You can keep the cannula on in place, okay? And you can connect it to make intra-arterial pressure. So you are able to measure now accurately the blood pressure continuously, which are very important. You can get a lot of blood sample easy without breaking more and more. So artery has a lot of benefit, which your colleague put it as indication. So it is very important, but we must suspect the complication and we must be able to know that we can make it persistent to take our blood sampling and measure the blood pressure. Okay, it is very simple technique. If you are ready, you understand the message, and you need to observe one, as I told you before. You need to observe one, assist one, do one, and teach other after that. Okay, so I will consider your marking after you write in your logbook that you already at least observe or assist in that whole procedure which you are presenting. Okay. I know that the time still you have some time. There is a challenge nowadays about the COVID breakdown, but we must go for that. Okay. Okay, we can go for the second presentation.
Bismillahirrahmanirrahim. Can anyone hear my voice clearly? Hello.
Yes.
Okay, thank you for the response. Assalamualaikum warahmatullahi wabarakatuh, and good morning. I bid to all. I'm Aznira Hanun. We'll continue presentation today with topic entitled capillary blood gas. Okay, next slide. Capillary blood gas sampling is the process of puncturing and collecting blood in infant, usually from capillary blood vessels. This allows the doctor to analyze the neonate's ventilatory status by observing the pH and partial pressure carbon dioxide. Okay. However, arterial blood gases is still gold standard test in sick patients or neonates who are at risk for sudden decompensation. Okay, next slide. Okay, capillary blood sampling can be obtained by near painless skin puncture using a lancet or automated incision device that punctures the skin to a depth of just 1 millimeter or up to 2.5 millimeter. It is the least invasive and safest blood collecting technique and can be performed by all healthcare personnel after minimal training. Okay, there are two sites for capillary blood sampling. First is at the heel. For an infant at birth up to 6 months with birth weight 3 to 10 kilogram, and then the placement of lancet is on the medial or lateral plantar surface. And for and then heel is most preferable in neonates. For the fingers, usually for the infants more than 6 months and more than 10 kilogram. For fingers, usually the third or fourth finger is preferred in infant more than 6 months and or all the children. And then the thumb was not preferred because there's a pulse and it's likely to bleed excessively. And then for the index finger is more sensitive and can be more painful. That's why we avoid prick the index finger. And then the little finger does not have enough tissue to prevent lancet from hitting the bone. And the placement of lancet must be on the side of the ball of the finger perpendicular to lines of the fingerprint. The puncture must be on top of the surface of the distal segment fingertip of the middle or ring finger. And then the puncture should be perpendicular 90 degree and not parallel to the fingerprint. Okay, next slide. Indications for CBG, capillary blood gas, is similar to ABG and VBG. However, CBG is indicated when arterial access is not available or if the infant needs frequent blood gas monitoring. So CBG will be done because it is less painful. Indications is to assess the ventilatory status, oxygenation, and active status, and also the response to an intervention. For regular electrolyte therapy, it means that to see the effect on electrolyte imbalance after intervention and help practitioners to regulate the therapy, usually in metabolic acidosis and alkalosis. Metabolic acidosis. And then to establish preoperative baseline parameters before surgical procedure done or any intervention was done. Okay, next slide. These are the common causes of blood gas disturbance, and usually in severe patient with severe gastroenteritis, DKA, short with type hypovolemic or cardiogenic and birth asphyxia, we will do the blood gas to rule out metabolic acidosis. And then in patient with pyloric stenosis, diuretics, and excessive NG tube losses to rule out metabolic alkalosis and respiratory failure due to illness or any other causes such as inadequate mechanical ventilation or CNS depression. To rule out respiratory acidosis and hyperventilation and excessive mechanical ventilation to rule out respiratory alkalosis. Okay, next slide. For CVG is contraindicated in patient less than 24 hours old, which is poor peripheral perfusion. And then site location not to be used is areas of infection, cyanotic or poorly perfused heel, fingers of neonates because it can cause nerve damage, and then less tissue in neonates, and then inflamed, swollen or edematous tissue, and previous puncture site. And then also contraindicated when direct analysis of arterial blood is needed. Really in very sick neonates because we want to accurate partial pressure of oxygen. And then the complications of CVD usually is cellulitis, osteomyelitis when when infection spread on to the bone, and then collapse of veins if the tibial artery is lacerated, and then nerve damage usually in fingers of neonates, and then hematoma scarring, and localized or generalized necrosis, a long-term effect. This is long-term effect. Okay, next slide. The list of equipments for CVG is lancet or heel prick device, capillary, second capillary or collection tubes, and then alcohol swab and cotton gauze. Okay, next slide. Okay, for the method, first we need to check the patient ID first, and then after that, prick the medial or lateral aspect of the heel. This is for neonates less than 6 months. And then for poorly perfused heel, warm with gauze, soak in warm water, and then clean the skin with alcohol swab, and stab the sterile lancet to a depth of 2.5 millimeter, then withdraw it. Okay, next slide. The first drop of blood we need to wipe away and allow a second drop to form. And then after that, we place a heparinized capillary tube in the drop of blood and allow it to fill by capillary action. And then fill the tube until the blood reaches the demarcation line on the tube. Maintain the blood in the capillary tube using index finger to maintain capillary tension on the end of the tube. And then after that, the sample has been collected. Seal both ends of the tube with the caps provided or with wax or clay as in the picture number 4. And then in the picture number 5, it is if we use a microtainer tube, so we need to touch the collector end to the drop of blood and allow the blood to flow down the wall of the tube to the bottom, and then cap the tube after the sample has been collected. And then apply pressure to puncture with side. Apply pressure to puncture side with dry gauze until bleeding stops. And then tape the puncture site to avoid the infection. Okay, next slide. Okay, here is the video.
This is an instructional video about how to collect a capillary sample from a neonate. When sampling, be sure to always follow your hospital's procedures. Before sampling, confirm the patient's identity. Make sure there is good blood flow to the sampling site. Disinfect the puncture area. Make an incision of maximum 2 millimeters depth on the plantar surface of the heel. Wipe off the first drop of blood. Hold one end of the capillary tube horizontally into the forming blood drops, filling the tube and keeping air out. If blood is not forming freely, very gently squeeze the lower leg and ankle. Carefully seal the incision site. Mix the sample thoroughly by inverting it slowly. Using a magnet enhances the mixing. Label the capillary tube with patient ID and immediately transport the sample to the blood gas analyzer.
Okay, that's all from me. Here is my references. Doctor.
So why we are breaking the lateral, not the middle side of the heel?
Because the middle side of heel there's bone, and if lateral more tissue, we can avoid the from hitting the bone.
Yeah, so there is two benefit. One benefit to be a bit far from the bone, because one of the side effects, if the needle is not so sterile or the procedure is not so sterile, there is documented cases of osteomyelitis on the heel. Okay, if you break the bone with no complete sterilization, there is a cases of osteomyelitis can happen. Another area, this in between, in the middle, there is a fascia here. If you are breaking the fascia a lot, it can be like affecting this fascia, which after that, if the one become elder, it can be weak point for him during walking. So we didn't prefer to break the middle at all. Okay. It is very, very simple, and we still use it even in neonate if we don't have arterial line or venous line. Sometimes we can go, but with precaution also. Okay. Who is the next one to present?
Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Umila Khalwati Yaakob. So I will be presenting the next procedure, which is the central venous line insertions. So what is central venous line? It actually an indwelling device that are inserted through different routes or sites into a large central vein, with its tips lie within the proximity of the superior vena cava or the right atrium or the inferior vena cava. So this access device, it includes central venous catheter that be inserted at either subclavian side, interjugular vein, or at the femoral side, femoral vein. And there are two types of central venous catheter, which are the tunnel and non-tunnel. So the tunnel central venous catheter are placed under the skin, and is meant to be used for a longer duration of time. And for the non-tunnel catheter, they are designed to be a temporary one and may be put into a large vein near the neck or the chest or at the groin. And then the second device is a peripherally inserted central catheter, PICC, in which the line are inserted peripherally, usually via the cephalic vein in the upper extremity or the saphenous vein in the lower extremity. And the third one is the implantable access port. And the last one is the umbilical catheter, in which the line can be inserted via the umbilical artery or umbilical vein, in which it is useful in few days of life in neonatal phase. And then, so in a selected seriously ill patient, pediatric patient that require resuscitation and emergency treatment, so this line must be inserted by a trained senior doctors. And ultrasound may be needed as a useful adjunct in the placement of the central line. Okay, so this table is the summarization on what I said earlier for each central venous access device with its routes and with specific indications. You guys can take a look later because I just want to share about the general one. So the indication for the central line in children is quite similar in those in adult. So for the general indication, central venous line insertion done is whenever the peripheral access cannot be achieved. Then it is also used in children with a chronic illness who often require prolonged or repeated venous access for treatment, or used in patients that require longer term intravenous infusions or frequent blood draws while warded, and it is also used to obtain central venous pressure for monitoring and used for hemodialysis. Other than that, it also used to deliver larger volume of irritating solutions such as antibiotic, blood products, dietary nutrition, media, or sclerosing chemotherapeutic agents. And last one, it indicated for patient that seriously ill ventilated pediatric patient, which especially with those in those with difficult peripheral venous access while in emergency setting. And then central venous insertion was contraindicated in case of a lack of consent in a non-emergency setting, absence of trained doctor for this procedure, especially in emergency situations, and then patient with known bleeding or clotting disorder, known venous thrombosis of the vessel, or in patient with uncorrected coagulopathy. And it is also not recommended to do this procedure if there is any skin lesion, infections, or burn over the desired insertion site to prevent for the bloodstream infection and so on. And then if in those patients with a severe abdominal trauma or with risk of contamination of the cannulation site by urine or feces, so better not to proceed for femoral vein cannulation. Or if there is no access because of the obstruction of the vein by a tumor or mass, or there is abnormal vessel. And the last one, when we compare to the peripheral line, so the ability for the central venous line to achieve the ability to achieve the same objective with a peripheral line, so better not to proceed for the complex procedure. So these are, so for complication, so this is a long list of complications that depending on the site of each venous line catheter was inserted. And it can be occurred during insertion of the line or after finishing the procedure. So for complication during insertion the line, so the most common one are the failure to place the catheter, about 22% cases occurred, and then arterial puncture, around 5%. Then problem with guide wire knotting or fracturing, hematoma at incision site, and pneumothorax. And last one is pneumothorax, about 1% cases. And then the common complication for post-insertion are listed at the top, which are accidental dislodgement, problem with catheter, either bloodstream infections, malfunctions, migration, or occlusion, in which it requires further management later on. And then these are the equipment used in this procedure, which are, the first one is the sterile set. The second one is the lidocaine, 1% for local anesthetic, together with 2 mil shrink and 23 gauge needle. And the third one is the 5 mil shrink with normal saline, together with T connector and 3-way tap. And the next one is Seldinger cannulation set, which consists of shrink, needle, guide wire, and catheter. And the most important, and the last one, the most important thing, equipment that provide for a sterile environment, which is sterile dressing. So for the methodology, I choose a femoral vein cannulation. So actually, the preparation for inserting other types of central venous catheter is quite the same. It's quite similar. So I explain the flow first, how doctor perform this procedure. After that, we watch a video for more understanding. So in a ventilated child, we give a dose of analgesia, such as morphine or fentanyl, and sedation, such as midazolam. So in the supine position, we expose the chosen leg and groin in a slightly abducted positions, and then identify the landmark by palpating the femoral artery pulse in the mid-inguinal region. And so after that, we can locate the femoral vein, which is located medial to the femoral artery. So for in infant, it's around about 5 to 6 millimeter distinct, and for in adolescent, it's 10 to 15 millimeter. And at this moment, it is recommended to use ultrasound guidance for this procedure. And then we clean the inguinal region using iodine and 70% alcohol. Then infiltrate local lidocaine at the proper site of the skin incisions. So syndical technique, for this procedure, syndical technique is commonly used to obtain the safe access to the central vein, in which we insert the saline filled shrink and needle at 30 to 30 degree angle to the skin and parallel to the femoral artery positions. And the needle insert the skin must 2 to 3 centimeter below the inguinal ligament, and towards the vein, it must 1 to 2 centimeter below the inguinal ligament. And then pull the plunger gently and advance superiorly in line with the leg. So when there is a bad flow of the blood into the shrink, so stop the suctions and disconnect the shrink from the needle. Then gently insert the guide wire into the needle like this. Then the next one is withdraw the needle gently and carefully without risking damage to the guide wire, including kinking or fracturing the guide wire, because this will lead to difficulty or inability to remove the guide wire after the catheter insertion later on. And then next, so dilator and scalpel blade are used to make a space for insertion of catheter later on. So next, once we remove the dilator, we insert the cannula over the wire without risking displacement of the wire into the patients, or we lose the guide wire. So we better prevent it. And then we remove the guide wire gently and check for the easy backflow for gentle suctions of the shrink, and flush with normal saline and attach the infusion line securely. And then the last step, we secure the line using the sterile dressing. So let's watch a video for more understanding. So this is the first step. Patient was sedated, ventilated, and already exposed the desired area for central line insertions. So the area are cleaned thoroughly, and then he put the sterile drapes. And these are the equipment used throughout this procedure. Central line key. And they also monitored the vital signs throughout this procedure. So needle are inserted at 30 degree to the skin. So we can see there is a backflow. There is a backflow of blood when he pulled the strings. So then he insert the guide wire slowly. After that, so he removed the needle, then use the dilator to make space to insert the catalytic on. So the dilator was inserted there. And he also used a small scalpel blade to make a small cut of the skin. So remove the dilator. Then he insert the catheter with the guidance from the wire. So make sure throughout the procedure not to lose the wire into the patients or kinking or fracturing the guide wire. Okay. And then he removed the guide wire. So the next step is to check the blood flow to see the functions of the catheter. And then he flushed a little bit of Lawrence line to check all the catheter. And then secure the catheter in place by suturing it to the skin. So when finish the suturing, so the last part is the dressing. So dressing. And cover the catheter after that. And make sure it's visible at all time. Okay. Okay, I think that's all from me. Is there any questions? Or doctor want to add something?
Do anyone need to ask any question? So the most important now is to know that infection control are very important. We have a class B form in every critical unit, which is a central line infection form. And even for peripheral cannulation for the venous like that, we have also incident report if there is any thrombophlebitis. It is very important to know that sterilization are very important. If we come back to the picture of the central line, and it will be applied for any sterilization, it must be central. I mean, you will start by cleaning the area of insertion and then do a cycle around. Don't start from outside and then go inside. Did you understand? So
Yes,
I
doctor.
do sterilization on the focus in the area which I am going to insert, and then I am trying to increase the cycle around it until complete sterilization. Okay. The issue of inserting a line is very simple. There is a vein, and you need to define its course. And remember, especially for the vein, is better seen than felt. The artery is better felt. Sometimes you can see, but you can feel the pulsation. And the collaterals are very important. At the point, you need to define the course of the vein or the artery you are going to give, and you will define the degree and the distance. Suppose you are inserting in the dorsum of the hand and it is a short vein, so you cannot go, so you must start slightly before like that. So you must be able to judge. There is a vein or there is a vessel, vein or artery in front of you, and you need to ask yourself what is your procedure, how to do it by complete sterilization. At the same time, you must get consent for this, especially arterial one, okay? And then you just go to your target. Is it artery? Is it vein? Is it just for sampling, or it is indwelling the catheter? You need to keep it for some time. It is very important, like this one. Of course, for children, if you are able to sedate the children, it is the best. But take care, we have some conscious sedation. But if the dose is high, he may need ventilation. So take care, like this patient is ventilated. I can give him deep sedation, so he will not struggle at all. But the other one, the conscious sedation, still he can move like that. So you must take care, because if you give him deep sedation, he may need to be ventilated, okay, which are very important points. The most important, as I told you, don't be afraid. If someone afraid from anything, he can do it. So you must be very challenging, know the complication to avoid it and to predict it early if it happens, like insertion of UVC, UEC. Sometimes it can cause blanching. Where is the picture of the UVC and UEC? Can come down. Come to the picture which contain UVC and umbilical stem. Yes, umbilical stem. Yes, you see this is the umbilical stem to the right. Okay, you can see now we have 3 vessels, 1 vein and 2 arteries. Okay, the vein will be patulous and thin wall. The artery is thick wall and circular and rigid. So you must define. It is very simple, just to go through it and insert the venous UVC and the arterial, which UEC in your need. It is very, very, very simple. And if you did it under complete sterilization, it will prevent the baby from a lot of breaking and a lot of difficulties in getting blood sampling or blood gases and like that. So it is very important. But as I told you, you must try to define the vessel and define your situation, prevent infection, and you can, after that, you can feel happy that you are able to do any insertion or any blood which you needed for the patient is assembly safe. So please keep your procedure assembled by a lot of knowledge. Don't be afraid and make it safe. And inshallah, you will be a good professional if you practice more and more. Okay, let's go for the next one.
Okay, next we're going to discuss about urine culture and sensitivity. My name is Anissa binti Rashidan. Okay, next slide. Previous slide. This is my table of content, which composed of introduction, indication, technique of urine collection, list of equipment need, and then methodology of procedure as well as complication. Next. So introduction, what is actually urine culture and sensitivity? Urine culture is a test to grow and find the causative organism that caused the infection inside of the urine. Meanwhile, sensitivity test means that to determine what kind of medicine, such as antibiotic, that will work the best in order to treat that infection. So this being considered as the gold standard in order to diagnose someone with a urinary tract infection. So the collection of the urine can be done either at the outpatient setting or at the clinical ward. Next. So the indication for those who need to do this urine culture and sensitivity, the first one is patient with the sign and symptoms of urinary tract infection. Second is the recurrent urinary tract infection. Third, those who are having fever or alteration of consciousness without any evidence of a source. And then finally is part of an evaluation of sepsis when there is no clear source has been established. Next. The technique of the urine collection can be divided into non-invasive and invasive. For the non-invasive, we have urine bag, clean catch, as well as voiding stimulation. For the invasive, we have catheter and suprapubic aspiration. Next. So first, we're going to discuss about urethral catheterization. So what are the list of equipment that we needed? The first one is sterile drapes and glove. Second is an absorbent underpad. Third is antiseptic solutions such as povidone iodine and chlorhexidine with the applicator sticks. And then cotton ball or gauze pad, and then sterile water-soluble lubricant, and then sterile cup at the picture below, and then urethral catheterization size varies according to their age. If they are neonate full-term to the 6 month, we will use 5 to 6 French. For infant or toddler, 6 to 8, and then pre-pubertal child, which is 10 to 12, and adolescent 12 to 14. Next. The methods for the urethral catheterization in male. First, soak the cotton swab in antiseptic, and then clean the glands and the distal phallus from the center to periphery, and then use our non-dominant hand in order to hold the penis vertically and gently retract the foreskin, and then use our dominant hand in order to clean the urethral meatus 3 times in a circular motion, and then lubricate the catheter by using the lubricant. And then first, before entering into the urethra, check first the balloon of the Foley catheter, either it is working or not, and then slowly insert it into the urethral meatus with the dominant hand by using the fingers or forceps to advance it downward. And then, however, along the way, if let's say you felt any resistance, it can be either at the level of the prostate, which can be overcome by using the steady pressure. Do not push or pull the catheter to get it past. And then once it be inside of the bladder, there will be the urine outflow. And then inflate the balloon with the sterile water, 3 to 5 cc, and then gently tuck the catheter to reduce the remaining length of the catheter, and this will allow the Foley catheter to rest upon the bladder neck securely. Next. Okay, this is a video of the male urethral catheterization.
And then discarding after each use. So again, just in circular motions, and then place into the bin. And then we can get rid of this piece of gauze and these first set of gloves. I'll just put my empty wrapper in the bin as well. Okay. So just wash my hands again, and then put my second pair of sterile gloves on. And then we have a drape, which I've already torn a circular hole in before we started, but you would do that at this point now. And then place this with the penis through the hole. And then we're going to make another sling with our gauze. Get our catheter ready. So the next thing that we need to do is put some instiller gel into the urethra. So I'm going to squeeze a small amount out onto the sterile field to begin with that we'll use to dip the tip of the catheter in. And then using our sling, just put that around the penis to hold it up. Going to insert the instiller gel into the urethra. Okay, and then we can discard that syringe. So holding the penis in an extended position for a few minutes to allow that instiller gel to work. We'll then open our catheter. Place it in the kidney dish nearer to the patient and dip it in our instiller gel. So then we're going to insert it into the penis. It should pass relatively smoothly. You want to extend it right up until the bifurcation, if possible. Okay, then we'll remove this plastic. So at this point, the urine should be coming out. If it isn't, it may just mean the patient needs to be repositioned. But we can place the bag onto the end of the catheter, then using our other syringe.
Okay, can pause.
Inflate the balloon.
Okay, basically this is the video of the catheterization that been done. Next. Okay, for the urethral catheterization in female, first position the patient into the front leg position. This is in order to help to visualize the urethral opening and vaginal opening. And then apply the povidone and then insert the catheter to the urethral opening. Female urethra is short with the upward angle. For the fourth, fifth, and sixth step, which is actually similar to what we have done in male. Next. Okay, next we have suprapubic aspiration, clean catch, and urine bag. So what is suprapubic aspiration? It is the gold standard of obtaining an uncontaminated urine sample, and it usually been done in the infant less than 1 year old, but also applicable in children up to 4 to 5 years old. And then the method how it been done is that with the child lying in the supine position, like referring to the first picture, a fine needle attached to a string is inserted directly into a bladder 1 to 2 centimeter above the symphysis pubis under the guidance of the ultrasound. So you can refer the second and third image. It may be used actually this method in severely ill patients which require urgent diagnosis and treatment but considered as invasive. Next, we have clean catch, which is in a child who is bladder trained, sampling into a wetting clean pot when the nappy is removed. So the idea is that we ask the patient to urinate, and then at the midway of the urination, we collect the urine. And then we have urine bag, which is applied to the perineum after careful washing, although there may be skin contamination. And for this method, usually there will be higher likely to be contaminated because of the diapers. And then positive culture should be confirmed with a clean catch or suprapubic aspiration specimen. Next. So let us see the first video regarding about suprapubic aspiration.
Pubic symphysis using an antiseptic solution. You may choose to leave the diaper on during the procedure to reduce spontaneous urination. Drape the area to avoid contamination. Next, infiltrate the subcutaneous tissues approximately 1 to 2 centimeters above the pubic symphysis with 1 milliliter of lidocaine. Use the 1.5-inch needle to perform bladder aspiration. The needle should be placed at an angle that is perpendicular to the abdominal wall, which means the needle will be approximately 10 to 20 degrees from true vertical. Penetrate the skin and immediately apply negative pressure to the syringe as you advance the needle through the skin until the urine is visible. You may feel a change in resistance as the needle penetrates the bladder wall. If no urine is obtained after the initial attempt, withdraw the needle to the edge of the needle tip, but do not remove the needle from the skin. Then change the angle of needle entry so that the needle tip is more caught at. The needle should be oriented along the true vertical. Once you have collected sufficient urine in the syringe, immediately transfer the urine to a sterile container.
Okay, now let us see the next video. Okay, next we can move on to the next video.
To catch the urine into the bag. The first thing you're going to do is take the moist towelette that comes with the kit. Sometimes they come with it, sometimes they don't. And you are going to cleanse the baby. So our little guy, I'm going to put his legs up so it's easier to get to. We have a little boy baby. And so with little boy babies, you want to make sure that you go around their urethral opening. So if they have foreskin, you may need to push that back and clean that. But you want to take your little towelette and just wipe once around. And if you need additional towelettes, then get those and make sure that the baby is clean. So once you have the baby clean, if it's a little girl, then you are going to wipe once front to back with each towelette. So sometimes you need to do that 2 or 3 times with separate individual towelettes. All right, so we have our bag, and the bag has a peel and stick on it. And so we are going to put this right over this little guy's bottom area. Let me lift him up so I can show you. So you can see, is it in zoom? Is it in focus? Mm-hmm. So you can see that the bag is covering his genitalia, which will allow him to urinate
there are several.
into...
This is how the urine can be collected. Next. Okay, after we have collect the urine sample, so what we need to do next is actually by culture the bacteria on the agar medium plate and incubate it for 24 to 48 hours at the room temperature, at the 37 degrees Celsius. And then it considered positive when there is any growth by suprapubic aspiration. For the urethral catheterization, whenever it is more than 5 to the 10 power of 4. And then for the midstream clean catch, it is more than 10 to the power of 5. It's been considered negative when there is no growth at all. And then next is do gram stain test in order to identify the bacteria as well as antibiotic susceptibility test. Next. So what are the complications? First is without adequate care, specimen can be contaminated with perineal, vaginal or periurethral flora. Second is usage of catheter can introduce to the new bacteria. And then the next one is that it will cause complicated UTI, urosepsis. That's all from me. Thank you.
Okay. Thank you. Good presentation. You didn't present ultrasound guided. How can be done?
Oh, I need to show ultrasound guided.
You have the video?
No, I'm not. I do not insert it into the slide as well.
Outside can be yes.
If it is simple, yes, you can.
But
we need to keep
someone that Dr. Sophie knows, somebody else.
No, we can set, but not integrated. And we can keep two from inside. If they have one, we have data. So after that, we can close it. We can do it. We can close and keep this from inside. Okay. Yes, sorry. Can I see the video with ultrasound? Because I need also to, you are year 5.
Yes, can you hold on?
Soon needs your service. Maybe inshallah able to join house officer a bit earlier. And if you start your life by challenging, as I told you before, nothing
right side.
This ultrasound machine is available everywhere. If you start to get hand-on, it is very good for you. And really, especially if some of you have imaginary brain, it is working very nice. Now you can do like ultrasound for every part of the body, very, very simply, and you can get a lot of knowledge, okay, which can guide you during the acute decision. Can we see this, please? It is just a simple prop. You can see, okay?
Yes, this video.
Gel to the abdomen, approximately 1 to 2 centimeters. The patient volumes for the caudad. The use of bedside ultrasonography to assess the bladder volume before you start the procedure and to guide aspiration can increase the likelihood that the procedure will be successful. The most common reason for not obtaining urine with suprapubic bladder aspiration is a lack of urine in the bladder. Ultrasonography can be used to assess bladder volume before beginning the procedure. Position the patient as shown earlier. Note the location of the indicator on the ultrasound probe and position it pointing towards the patient's right side. Apply ultrasound gel to the abdomen approximately 1 to 2 centimeters superior to the pubic symphysis and locate the bladder. Apply minimal pressure with the probe in order to avoid triggering urination. A full bladder in transverse view will appear as a well-defined triangular or rhomboid structure in the pelvis containing black or anechoic fluid. In this orientation, the patient's right side will appear on the left side of the screen and the patient's left side on the right side of the screen. If you obtain measurements of more than 2 centimeters in all dimensions, you should be able to aspirate at least 2 milliliters of urine, an amount that is generally sufficient for analysis. If there is very little urine in the bladder, you may find it difficult to locate the bladder with ultrasonography. If this is the case, provide the patient with oral or intravenous hydration as appropriate to the clinical state of the patient, and try using ultrasound guidance to locate the bladder 30 minutes later. The amount of fluid you administer will depend on the size of the patient, the level of dehydration if present, and whether there is any known cardiac or renal disease. Once there is sufficient urine in the bladder, you may begin the procedure. Prepare a small amount of sterile gel and put on sterile gloves. Cleanse the skin with the antiseptic solution and place a sterile cover on the ultrasound probe. Locate the bladder again. If you are not using ultrasonography for real-time guidance of bladder aspiration, mark the skin site where the bladder is best visualized with a sterile pen and proceed with bladder aspiration as demonstrated earlier. For real-time ultrasound guidance, leave the probe on the abdomen and insert the needle midline and just inferior to the edge of the probe at an angle that is perpendicular to the abdominal wall. You should see the needle tip clearly on the ultrasound screen as it advances through the skin and into the anterior wall of the bladder. Once you see the needle in the bladder, aspirate the urine. Complications of suprapubic bladder aspiration are rare.
So that is very important. Please keep in your background the importance to, if you would, the chance to start early using this probe of ultrasound machine. It will help you a lot. It can help you for this bladder. It can help you if you need to go central line. You can just put it also to see the femoral line, artery and vein, so you are not going to cannulate the femoral artery instead of cannulating the vein. You can do it also to confirm the position of the catheter. If you are inserting UVC or UEC or even BICC, you still can see it through. Now they are trying to replace the ultrasound for a lot of X-rays. As you know, X-ray is not so safe for exposure and for possible complication. So it is very important to put it in your view. Please try to start early. And if you start early, you are still young. I saw some even senior house officer who became very good in ultrasound because they have a good imagination. They are keen to be educated and give time for that. You can read, you can observe, you can then assist, then you can do, and inshallah you can teach others. I hope you got that one. And remember, please, that every procedure has its own challenging. Don't be hesitated, know the challenge, and go ahead without hesitation. You need to ask me anything or Anissa about the last presentation. Okay, so you are group 2. Which group are you?
Group C.
Group C.
Yes.
Group C.
Yes.
Okay, group C. I will send you the result, your marking now. Just write it in your book, and I will. I think. Did you send me your logbook?
Logbook already sent to our mentor.
You are not in my group.
No.
Okay, you can. I will send you the result. You can add it to your book. Okay.
Can we WhatsApp you later because we want to get the mark and send to Kak Farah?
Sorry.
We need to submit the marks to Sister Farah.
Okay. Okay. You need me to send it to Sister Farah?
Yes. Later on we will WhatsApp you.
No issue. I will send you, not to be forgotten. Okay. So you are for presenter today.
Yes.
Noor Laylatul Qadr or Laylatul Nazira?
Laylatul Nazira.
Okay. And Amira and Al Khair and Anissa. Yes?
Yes.
Okay. I will send it. Okay.
All right, Doctor. Thank you.
You need to ask any details or anything?
Doctor?
Yes.
I have a question. For arterial blood gases, usually can we do it in 90-degree position for the needle?
No, we didn't prefer to go for 90 degree. because in some situation, if there is difficulties like that, we can do. But usually, if the probability to cut the artery from both sides, I mean, you will penetrate the artery from anterior and posterior, are very high. And if you try to come to big it in the middle, you cannot insert anymore. Did you understand?
Yes, Doctor.
Yeah, so it must be angulated to the artery like this. So you are able, when you puncture the vein, you can able to push it slightly. But if you go perpendicular, you will cut the artery, you will bypass it, which can cause a lot of bleeding. Am I clear?
Yes, Doctor. Thank you, Doctor.
Okay. Okay. Thank you, Goma Mubaraka, and hearing good news about you.
Okay, thank you, Dr.
Thank you,
Assalamualaikum.
Doctor.
Group
Doctor.
C, yes. Group C.
Yes, yes.
Seminar for 3. Okay, thank you. Assalamu alaikum wa rahmatullah.